Hello everyone, good morning and welcome to today's discussion about malignant hyperthermia. Malignant means harmful or dangerous for health, and hyperthermia means increased body temperature above the normal. We know that our normal body temperature is around 98.6 degree Fahrenheit. In case of malignant hyperthermia, body temperature is sustainably increased around 105 degree and above. This is life-threatening inherited pharmacogenetic disorder of skeletal muscle. I am repeating again, life-threatening and inherited pharmacogenetic disorder of skeletal muscle. And also it is hypermetabolic crisis which is triggered in susceptible person by certain anesthetic agents. Incidents and who are the sufferers? If we see the international study where in case of adult, the incidence is 1 in 1 lakh, and in case of children, 1 in 15,000. Who are the sufferers? In sarcoplasmic reticulum, ryanodine receptor genetic mutation occur in susceptible person, and they will suffer, or there may be chance of malignant hyperthermia. Ryanodine receptor of sarcoplasmic reticulum in normal state release certain amount of calcium in sarcoplasma and causes normal muscle contraction, where ryanodine receptor mutation is mutated. This mutated ryanodine receptor is so much sensitive to some anesthetic agent, and their sensitivity increase their activities, and they release more and more calcium from sarcoplasmic reticulum to sarcoplasma. If we know the already we have discussed about the pathophysiology, the mutation occurs in the ryanodine receptor in the sarcoplasmic reticulum, which is so much sensitive to some anesthetic agent, mainly volatile anesthetic agent such as halothane, sevoflurane, isoflurane, desiflurane, and also for pupillizing muscle relaxant. In recent study also shows that amide type of local anesthetic may cause the malignant hyperthermia. We have already discussed that this is hypermetabolic state. Why it is hypermetabolic state? In case of mutated ryanodine receptor, which is so much sensitive to certain anesthetic agent, they fail to control their regulations, and as more and more calcium is released from sarcoplasmic reticulum to sarcoplasm, and this calcium causes sustained and dramatic increase in skeletal muscle contraction, where the skeletal contraction of the skeletal muscle activities is increased. Their consumption of ATP also increase. As the ATP consumption is increased, or breakdown of the ATP is more, increase the body temperature also. As skeletal muscle contraction sustain and more increase, their demand of the oxygen is also increased, which exceeds the supply of the oxygen. As a result, anaerobic metabolism occurs and lactic acid and other byproducts may be produced. As the sustained and dramatically increase of the skeletal muscle contraction, the cellular membrane is breakdown and release of the potassium, myoglobin, and creatine kinase also. What is the clinical presentation? Though the name is malignant hyperthermia, but hyperthermia or body temperature is increased in late stage. In early stage, we will find the unexplained tachycardia, where the heart rate is more than 150 per minute. Why tachycardia? When sustained and dramatically increase of the skeletal muscle contraction, there is also demand of oxygen exceeds the supply. In this situation, heart try to compensate and pump more and more acid as a tachycardia. This is the early sign of malignant hyperthermia. Also, if we measure the end-tidal carbon dioxide, here more oxygen is consumed due to skeletal muscle contraction, and more carbon dioxide is produced, which is unable to compensate by normal ventilation. As a result, carbon dioxide is trapped within the body, and the end result is internal carbon dioxide. In case of muscle contraction, mesenteric muscle spasm is the early sign, and the late sign is hyperthermia and generalized muscle rigidity, metabolic acidosis, hypoxemia, arrhythmia, and rhabdomyolysis. How can we confirm that is it malignant hyperthermia or not? Clinical presentation is the And clinical sign is the main diagnostic tool in case of malignant hyperthermia, because if all the sign is present and during anesthesia, we must confirm that this is malignant hyperthermia due to anesthetic agent. We can also confirm by some other test, caffeine halothan contracture test. The small biopsy of the muscle, if we exposed in caffeine and halothan, we can see the contraction of the muscle. This is the invasive procedure and only present in some other higher center and specialized centers, not available in all centers. And more accurate test is genetic testing. Genetic test of ryanodine receptor RY1 gene is more accurate test. Management is so much crucial for anesthesia or anesthesiologist. We can follow some protocol, that is stop, call, give, cool, monitor. Stop. When you suspect the malignant hyperthermia by monitoring the sign symptom during anesthesia, immediately stop the anesthetic agent who is sensitive to ryanodine receptor, such as volatile anesthetic agent and succinylcholine, and call for help. This is life-threatening condition. As it is life-threatening condition, call for help. The whole team, and the specific treatment is the dentoline sodium. Dentoline sodium is direct skeletal muscle relaxant also, and it binds with the receptor and inhibit the release of calcium from the sarcoplasmic reticulum to sarcoplasm. Initial dose you can start 2.5 milligram per kg every 5 to 10 minutes, and we can increase up to 10 milligram per kg body weight. And other measurement also we will have to take, as the sustained and dramatically rise of the body temperature above 150 degree, 5 degree or above. So we will try to cool the body temperature or decrease the body temperature. We can try IV cooled saline, gastric lavage with cold water, surface cooling with ice pack, and cold lavage of cervical cavities if applicable. And in the meantime, we will have to monitor the vital signs, heart rate, blood pressure, oxygen saturation, etc. And some other lab investigations also help us. Serial ABG, hyperkalemia, like potassium level for hyperkalemia, electrolytes, and coagulation study also, and catheterization of the patient to monitor the myoglobinuria and urine output, and ECG monitoring for arrhythmia. Post-crisis management. If we accurately manage the patient Then after the operation, we must have to send the patient in ICU for 24 to 48 hours for monitoring to see the any other recurrence. And we will also have to continue the dental sodium 1 milligram per kg body weight every 4 to 6 hours for 24 to 48 hours. And all other supportive care must have to continue. What will be the future care of the patient and the family? Patient and the patient family must have to inform about the diagnosis of the patient, and they must wear medical alert bracelet for malignant hyperthermia susceptible patient family, as it is genetic inherited disorder. And all family members must have to refer for genetic counseling and testing. Thank you all.